Do you hear me okay?
Yep.
Perfect. Well, good morning, everybody. My name is Evgeny Karatin. I'm one of the cardiovascular disease fellows at St. Luke's Mid-America Heart Institute. Thank you for attending this session on ECG board review with Dr. O'Keefe. He will go through a series of interesting ECG cases to assist us with optimizing our coding approach in the upcoming cardiovascular disease board examination. We look forward to your participation. Please, as common courtesy, remember to silence your microphones after finishing participation. All questions can be in most part directed towards our chat box, and I will try my best to get to those questions throughout the presentation. And finally, again, we very much encourage your participation and feedback during the session to make this as interactive as possible. One other sheet that I was going to show here is the EKG scoring sheet. This is to help assist you as we go through the EKG coding process. If you want to take a few seconds here and just take a snapshot if you're on your iPhones or computers, just so that you can have this for your reference. I'll give you 5-10 seconds to take a quick picture and we will get started. All right. Dr. O'Keefe, if you want to go ahead and share your screen.
Okay.
Perfect.
How's that look?
Looks great.
All right. Well, we'll just start into this. Just a couple of sort of tips on overall the ECG portion of the boards. It's an important part of the test. I don't know this for a fact, but there's been a rumor for a long time that there are, like parts of the board that are sort of like mandatory, and there may be portions of the ECG that are mandatory. If you miss it, they figure if you aren't ready to be a cardiologist, a board certified cardiologist. So I'm going to show you some tracings that often occur. I've been doing this for decades, I think like 3 decades, and I always ask the fellows after they finish their test, what was represented. So I have a pretty good idea of the kind of ECGs that are going to be on there. I'll tell you, it's important to pay close attention to the stem up at the top, the lead-in, the clinical scenario, as it is in the clinic or in the hospital. But on the boards, they will definitely, so give you clues about what this might or might not be. So anyway, okay, let's go ahead. And this is a 26-year-old male who comes in and complains of heart racing, intermittent heart racing. So anybody want to, and feel free, you don't need to like get detailed about it, but it's fun to kind of just put your bet down, and then we can discuss it. Anybody want to chime in on this one?
I can start it off, Dr. O'Keefe.
Okay.
So yeah, the vignette is a 26-year-old male, young patient. It's a narrow complex, what appears to be a narrow complex tachycardia, with what looks to be kind of an initial or a kind of an RSR prime pattern, suggesting a short RP tachycardia. An AV-NRT would be my initial diagnosis here.
Perfect. All right. So for the board score sheet, and this what we're using to do these ones today is called O'Keefe ECG. It's an online teaching website that's very interactive. And encourage you to think about subscribing to this. But there's about 220 ECGs. I'm adding more actually this week even. But so this replicates almost verbatim. There's a couple little minor sort of changes in the verbiage just to avoid copyright infringement on the board exam. But the same 89 diagnoses will show you. We'll be seeing these on the boards. So as Jeff said, this is supraventricular tachycardia. And it's I was kind of trying to show you that this is that retrograde P wave there that you can see in multiple leads that immediately follows the QRS. These STT changes, this is an 26-year-old. This is not ischemia. This was a 66-year-old male, with a history of CABG, you might call it ischemia, but this you would call non-specific STT changes, which, it's kind of that's not an important part of this. The key on this is just, getting that supraventricular tachycardia. So, yeah, we got that one right, of course. So let's just go back here. On this O'Keefe ECG, one of the things we spent a lot of time on was, putting together way back, when I took the boards 35 years ago or whatever, I put together this consensus diagnosis for each of the criteria on the boards. And that's really important that you sort of really know those 89 diagnoses cold. It's a good thing to be cramming for before the boards actually. But one of the tricky things is like, what's the difference between atrial tachycardia and supraventricular tachycardia? Well, atrial tachycardia, usually you see a non-sinus P wave. Like over here, you can see this inverted P wave coming, probably from the bottom of the atrium. And it's over 110 beats per minute. And so that would be an atrial tachycardia where you can identify a P wave. It's definitely not a sinus P wave. And whereas the supraventricular tachycardia is usually the P waves are buried in the QRS or shortly before or shortly after, since it's coming from the junctional node. The AV node is usually the P wave is less distinct. So any questions on that one before we move on? Pretty straightforward. That's a tracing that you very well could see on the boards. Let's go way up here now. This one. Here's a 25-year-old female found unresponsive lying outside of a bar. It's actually up in Minnesota on a January night. Don't be shy. Anybody?
Oh, hey, Dr. Akif, this is Amar from Mount Sinai. I'll say this looks to be a normal sinus rhythm, normal access, looks to be a good R wave progression, and I would say prolonged QT.
Yep, it's a prolonged QT, and that this little notching over here at the end of the QRS, we often see a normal variant, early repole kind of things. When it's in the clinical scenario where this is a young person who's found lying outside of a bar on a Saturday night in Minnesota, passed out from inebriation, her temperature when she got to the emergency room was like 33 degrees Celsius. And yeah, so this is hypothermia, which is one of the 89 diagnoses. And oftentimes prolonged QT goes along with it, sometimes first degree AV block, or eventually get a prolonged QRS. So this is, hypothermia. And maybe I can, yeah, so see those arrows are pointing out these Osborne waves, which are the only time you see Osborne waves are, normal variant, early repole, hypercalcemia, and hypothermia. So let's just go back here and show you a more profound episode of hypothermia. Yeah, so lots of times with hypothermia, you get like atrial fibrillation or a flutter. This person has a flutter. The QRS is starting to lengthen out. So it's like, the flutter waves are slower and the AV conduction is slower. And you could see these giant, it's sort of a right bundle branch block pattern, but there's probably Osborne waves there too. So, yeah, and the cool thing about this is, you can, and eventually you can get, VT and BF. So that usually happens before people freeze to death. they get a dangerous rhythm. But so the cool thing is, like with this one, you warm them up, and there you can see there as their temperature rises, their ECG goes right back to normal. And a place where you might see this frequently these days is when we do the hypothermic, protocols after cardiac arrest. So keep an eye out for that tracing.
And Dr. O'Keefe, as far as the differences between the Osborne and the epsilon waves, is it primarily more a difference of the clinical condition under which the wave is seen, or is there something more than that?
Yeah, usually the epsilon wave that's seen with arrhythmogenic right ventricular dysplasia is more of a fractionated QRS, and you'll see this kind of this funny little sort of like QRS ditzel towards the end of the QRS. It's usually the clinical scenario is quite different. And the other thing is the ARVD is not one of the diagnoses on the board sheet, so you won't need to worry about that diagnosis on the upcoming board exam, although it's important, obviously, from a clinical perspective.
There was also a question about where the Osborne waves are more typically seen in which leads. I think that may have been at the bottom of the last case you had shown in the answer section.
Yeah, that is, I forget. I think it's, yeah, I'm not exactly sure. I guess we could, I'll tell you what, in this one, it was more of the anterolateral and inferior, which is, kind of where we see the J waves in the early repol findings too. So that's probably a good bet. Although, to be honest with you, I'm not positive about that one. All right. Here's an 89-year-old female during a routine office visit. So just by convention, I think a lot of places are like this, but here at St. Luke's Mid-America Heart Institute, pacing spikes are delineated by a green hashtag there. So green sort of, you see it there, little green marker. Anybody want to take a crack at this one? Some of these tracings are just examples of the various diagnoses that are listed on the board score sheet that you need to get familiar with. It doesn't need to be perfect. Just somebody
Okay,
like.
I'm gonna give it a shot. I am Bob from Montefiore. I think this is atrial fibrillation to PVC.
I'm sorry, I didn't hear that.
Atrial fibrillation, otherwise normal axis. No, I can't tell if these are PVCs or if these they are pacing spikes on the line.
Yeah,
These,
there's pacing spikes there, so
yeah,
they're not
pacing-
PVCs, right?
Yeah, so pacing spikes, and I think it qualifies as low voltage. I think they're all less than 10 in the precordial leads.
Yep.
Yeah, so
Yep, you got it. That's so it's atrial fibrillation. Low voltage in the precordial leads are all less than 10 millimeters, but over in the limb leads, they need to be less than 5 millimeters, and up in one, it's more than 5 millimeters. So, and those this is a fib with VVI pacing, and this beat over here, you might say, well, it looks like it's failure to pace, but this is what we call pseudo fusion. So, there's a pacing spike, and it doesn't really seem to capture, but that's because the native conduction from the atrium kind of beats it down the AV node, and even though there's a pacer spike, the native beat captures the ventricle before the pacing can. So this would just be atrial fibrillation over here, and then that would be normal VVI pacing. All right, and then there's also low voltage. I think we said the low voltage is up here. Low voltage in the precordial leads. You have the option of precordial leads or limb leads. I mean, there's some, this is subtle, and you might get a point for it, but there's some subtle non-specific ST wave abnormalities there, flattening of the T waves. It's a minor point, but just understand that's on the these non-specific STT changes are one of the board answers as well. So any questions on that one before we move on?
There was a question about the morphology of the paced beat in the precordial leads as far as it not being a left bundle branch block morphology.
Yeah, that's very perceptive. And then when you see that, you kind of see, like when you see that positive voltage, coming forward from the posterior part of the ventricle forward, that's usually a CRT pacemaker. It's a very good point. Usually you see Q waves over in one or AVL. It's hard to really see that in this instance because you only see one beat in one when you see the biventricular pacemaker. But yeah, that might actually be. And the pseudo fusion is out there, but you wouldn't expect it there. So there is a, it's a really important point. There is a biventricular cardiac resynchronization therapy, and that's how we make that diagnosis. We look at that. So I think I'll have to add that to the answers because you're right. That should be a big left bundle because it paces from the RV apex, so it goes from the anterior wall back until you get these big left bundle looking patterns with normal RV apical pacing. And when you see that positive thing up there, that's usually CRT pacing. Very good. All right. So this is a 28-year-old female who had severe mitral regurgitation from mitral valve prolapse. She's just a couple days, two days post-op for mitral valve replacement. And we do the ECG, and this is what we see. Anybody want to take a shot at it? We're not keeping score. Doesn't matter. Just don't want to waste too much time, contemplating here.
I mean, I don't see the P waves almost seem to be right after the QRS. So this is some kind of junctional escape or junctional rhythm.
Very good.
Yeah, some kind of I don't know if I would call the LVH on this one because AVL is over 11 millimeters, but I don't know.
Yeah, no, you're perfect. I mean, there's no reason not to call LVH. There would be if this is a ventricular rhythm. And for the ventricular rhythms, you don't call the axis, you don't call the voltage, you don't call, infarcts or Q waves or anything. You just call, VT or accelerated idioventricular rhythm or ventricular escape rhythm. But yeah, this is an accelerated junctional rhythm, often seen early post-operative for heart surgery or sometimes with digitalis toxicity, electrolyte abnormalities, various things. But yeah, there's no P wave visible. You're right. There may be a hint of a retrograde P wave up there in V1, V2. But yeah, this is there is a down here in the junctional rhythms. There's a junctional escape rhythm, but that usually is like 40 to 55 or 60. This is 65 beats a minute, and plus the scenario here is more of a accelerated junctional. So there's AV junctional rhythm or junctional tachycardia, and then you just call the LVH, and you'd move on to the next ECG. Usually they give you about 3 minutes per ECG for the boards. So yeah, accelerated junctional rhythm like acute myocarditis, stage toxicity, acute inferior myocardial infarction, or early post-op like in this case.
Two quick questions on this one, Dr. O'Keefe, as far as calling left axis in the setting of LVH, as well as how specific we need to be in terms of coding left anterior vesicular blocks.
Yeah, so I should have showed you, well, actually we can go. So So the thing is, this is not quite left axis. It needs to be, more negative than positive in V1, and then negative in in 2 in AVF, and positive and that's more than negative 30. So more than negative 45 is left anterior vesicular block. Things like left axis deviation and LAFB, you can still call, even though it's not quite as specific, but it's still very legitimate to call LVH, as we did on this one, even in the presence of left anterior vesicular block or left axis deviation. But let me just show you the classic left anterior vesicular block here. That will be, like I say, more than negative 45. Oftentimes you look for little Q waves, like there are here, tiny little non-pathologic Q waves in 1 in AVL. And then here, there's LVH on this one too. This is more than 11 millimeters, and you would call that. But importantly, if the QRS duration is more than 110 milliseconds, actually greater than 100 milliseconds, you don't call LAFB unless there's a right bundle branch block with it. So the LAFB should not prolong the QRS more than 100. If it does, you call like non-specific IVCD. But and then right posterior vesicular block. Left posterior vesicular block is a tricky diagnosis because it's basically right axis without any other reason for it. And this is an example of it. Left posterior vesicular block. Again, it should be less than 100 milliseconds in duration. And you'll see non-pathologic Q waves, this time in these 3 in AVF rather than 1 in AVL, like with LAFB.
There was one last question for the sake of time about whether or not to include sinus rhythm as for or code for sinus arrest, for instance, in the setting of a junctional rhythm morphology.
Well, yeah, that's a good question. If it's a slow junctional rhythm, then you could code sinus arrest, or if you see a sinus pause, of course. But in this case, when it's an accelerated junctional rhythm, it's 65 beats per minute, so it's just overrode the sinus rate here, so you wouldn't call sinus arrest here. That's another great question. A sharp bunch on the call today here. All right. This is a 70-year-old. Oh no, we don't want that one. That's too easy. Okay, so this is a 75-year-old male with non-ischemic cardiomyopathy complaining of heart racing. Shows up in the emergency department with heart racing, and this is the tracing. History of non-ischemic cardiomyopathy. Anybody?
VT.
VT, monomorphic VT.
Yep, monomorphic VT. So the things, so number one, you very well will see a VT on the among the ECG tracings. This one's very wide, 200 milliseconds. The wider it is, the more likely it is to be VT. There's not ventricular concordance, but there is this sort of bizarre notching. And then there's this other rule: if it's more than 100 milliseconds from the onset of the R to the nadir of the S wave, and this is more than 100 milliseconds there. Lots of times you see you see other features as well. Show you here another VT. This one, and again, usually it'll be like this, where you have a 79-year-old man with an LVAD in the hospital with fatigue and chest tightness. And in this case, this is another episode of VT. This is ventricular concordance, where the R waves are all the same direction across the precordium. There's an R in AVR, and then it's a northwest axis, so it's positive in 1 but negative in a 3 in AVF. And there's these bizarre notching going on, and then again, somebody with an LVAD, it's VT till proven otherwise. When you see a wide QRS, lots of times you'll see fusion beats and some evidence of underlying sinus beat and AV dissociation. But But we don't see that here, you know, so you just score the VT and move on. Any questions on that? Make sure we got all the
If you do see evidence of AV dissociation on the EKG, do you still have to code it if it's VT?
Yeah. Absolutely. Yep, you absolutely code that when if you see evidence for underlying, you know, but it can't just be a fusion beat or a capture beat. You have to be able to see the P wave, you know, because it could be, you know, some other rhythm that's coming through there, a junctional or something. So, but if you see a P wave, yeah. Well, the other thing, if it's a RBB, you know, normally the left rabbit ear is smaller than the right, but in VT, it's more likely the left rabbit ear will be taller in V1. Okay. This is a 62-year-old male with severe nausea and vomiting for 1 week. There are 4 different electrolyte abnormalities on the board score sheet, and you know, you'll probably see one of them. This is one example.
There's an answer in the chat box: prolonged QT and hypokalemia.
Yeah, very good. So this is yeah, big long QT, mostly due to this big U wave here. The U waves at the end of the QT interval and upright U wave, and yeah, this is hypokalemia, and there's also first degree AV block here. Well, maybe not. It's yeah, no, I guess it's not. That's something that's commonly seen with it. So this is hypokalemia, and let's look at another example of hypokalemia. You'd code. Here's another one that's, you know, another big wide. It has sort of a same look to it, like the one that looks a lot like this. Is a different tracing, but this one also has first degree AV block, and it's sort of a broad U wave.
Are you supposed to code for the prolonged QT if it only is prolonged because you're including the U wave?
Well, that's a good sort of good question, and I mean, in this answer, we gave like the more important thing was the prominent U wave here, but you know, since hypokalemia is U waves need to be more than 1.5 millimeters in amplitude, negative or positive, to be considered prominent U waves. And besides hypokalemia, you see it with things like bradycardia, hypothermia, LVH, RVH, coronary disease, several antiarrhythmics, and cardiomyopathy. But yeah, you know, you probably wouldn't get much credit for coding the hypokalemia. I mean, coding the prolonged QT, because it's mostly prominent R wave, but you know, in this, we said both prolonged QT, prominent R wave, hypokalemia, and then the sinus rhythm. So, yeah, good question.
And in this case, Dr. O'Keefe, there was a question about whether to code for nonspecific STT wave changes.
Oh yeah, really good point. Yeah, I failed to mention that there is a code of the 89 codes. This one's over in the repole abnormality spot. We have to remember to do this when it's STT changes suggesting electrolyte disturbance. So yeah, that's important. I mean, not super important. The important thing is getting the hypokalemia here, but you get a 0.22 for coding that the electrolyte abnormalities there. Okay, we have a 43-year-old diabetic male comes in complaining of pleuritic positional chest pain, diagnosed with a pneumonia after getting in the hospital. Last boards, there was one like this. Anybody?
Pericarditis.
Yeah, very good. Pericarditis. You know, you'd think about, okay, before you even look at the tracing, you'd say this is a male complaining of pleuritic positional chest pain associated with pneumonia. It's a no-brainer. You'd say, oh, is there pericarditis here? Yeah, oh, there's ST segment elevation everywhere. There's PR depression over here in like 2 and 3 and V5, V6. So yeah, this is classic. You'll see it ST segment depression typically everywhere except AVR, where it's the mirror image of that. Okay, so here's a 69-year-old male with syncope. He's got end-stage renal disease. He's on dialysis. Comes in with syncope. Anybody?
Sinus bradycardia.
Yeah, you'd think it's sinus bradycardia, but if you look closer, and this is pretty tricky because there's a P wave hidden in here, and it's it's shorter than the P to P interval here is shorter than the P to P interval here, and it's a consistent finding. And so this is actually 2-to-1 AV block, but it's something called isorhythmic sinus arrhythmia, and basically what it is. So I'm sorry, ventricular phasic sinus arrhythmia. When there's the P interval shortens up when it's like 2-to-1 AV block. It shortens up when there's a QRS in between the PP intervals, and then when there's not a QRS, the PP interval is a little longer. Somehow that conduction to the ventricle alters the depolarization rate up in the sinus node. But in any event, so, and look at like this ST segment is really long here. Somebody end-stage renal disease on dialysis. So besides the 2-to-1 AV block, anything else? This is actually a little longer than 110 milliseconds, so it's what we call a non-specific interventricular conduction defect, we would call that, even though it is a sinus rhythm still. So this is, and the QT is kind of long, but mostly the QT is definitely long. It's real long, but then when you adjust for rate, it's still long. It's about 490 milliseconds, and then but it's due to this long QT. So this is hypokalemia actually. So I'm sorry, hypocalcemia. Kind of tricky, but sometimes this is sort of a hypocalcemia. It looks like this with this big long QT, but it's due to a long ST segment before the segment before the QT lengthens out, and that's usually when you see it that striking, it's hypocalcemia. So hypercalcemia has a short QT and especially short ST. Here's a normal calcium level, and hypocalcemia is a big long, like this one, a long ST segment. So a little tricky, may not be on the boards, but yeah, you can see with hypocalcemia, you can see other like the rhythm abnormality, like in this case, the 2-to-1 AV block. And this was due to, like I said, this guy had really had high phosphate levels and low vitamin D levels. And so he was basically sort of like precipitating the calcium out of his arteries. So he had, I think his calcium level was only 6.9. Well, so in this one, of course, you'd also code the STT changes suggesting my electrolyte disturbance. Okay. Here is a 54-year-old male with syncope. He just shocked out of VFib in the emergency department. He still has chest pain now when he wakes up. Anybody?
ST elevations in AVF and depressions in V1, V2, maybe infraposterior MI.
Right, perfect. So an acute infraposterior infarction. You have this, ST segment depression with a still mostly upright T wave. And especially usually when you see an acute posterior infarction, it's in conjunction with an acute inferior infarction. On the boards, there is a repolarization abnormality called STT changes suggesting myocardial injury, which is, I think, a good idea to always score that when you have, in this case, you have an acute inferior MI, an acute posterior MI, and this rhythm. What do you make of this rhythm?
Complete heart block.
Yeah, it's just a big first degree AV block. Lots of times with acute inferior infarctions, you'll see high grade AV block or complete heart block or first degree AV block. But yeah, this is just first degree AV block. So and then you also code this PVC over there, right? So there's a ventricular premature complex. There's a sinus rhythm, sinus Brady. 1, 2. Yeah, I think it's a little sinus Brady. So just another hint for the boards. Normally you just look up in the reading of the ECG and it'll tell you what the rate is. But here on the boards, they usually won't give you the QT or the rate or anything like that. So just count the number of the number of P waves across the tracing and multiply by 6 because it's 10 seconds. So in this case, I think it's 54. If it's if it's less than 6 beats, less than 60 beats per minute, then of course you code it. So I think this is sinus bradycardia, but
while you're coding, Dr. O'Keefe, there are 2 questions, one about coding injury versus ischemia,
right.
And also in regard to the actual criteria for posterior MI.
Yeah, so the injury, so like when you see ST segment elevation, more than 1 millimeter in 2 contiguous leads, this is way more than 1 millimeter, or it has to be more than 2 millimeters in V2, V3 for males, or 1.5 millimeters ST segment elevation in females in V2, V3. If you see more than 1 millimeter of ST segment depression over in V1, V2, and V3, then especially with this configuration of this upside down, beginning of the, basically looks, if you flip this over and looked at the paper, the ECG from the opposite side, it would look like ST segment elevation. So that's the posterior infarction look to it. You'd call that definitely acute infarction. And when you see ischemia at a distance, like here, there's ST segment depression over in V1, AVL, you say, well, that's ischemia, or multivessel disease or reciprocal changes, but you don't call ischemia, like for the board purposes, it's either injury or ischemia, not both. So you would not on the boards, if you call acute ST segment infarction with ST segment elevation, you don't call the injury as well. Okay. So this is a 71-year-old asymptomatic male with a history of myocardial infarction. Anybody?
Looks like he has an old inferior MI. Yeah, sinus rhythm, sinus bradycardia. 1, 2, 3, 4, 5. Some of the tricky ones, almost bradycardia.
Yeah, it's about 55.
Yeah, so sinus bradycardia, old inferior MI, doesn't meet for LVH despite V3. He's a man, 1, 2, 3, 4, 5. So yeah, I would leave it at that, except something else. The limb voltage, is that 5? Lead 3, I think it doesn't meet in lead 3. I think that's more than 5.
Yep, just a little more than 5. Very good.
Yeah.
Yeah, so this is an old inferior infarction. There's this QRS duration that's like 100 and over 120 milliseconds here, but it's not left bundle, it's not right bundle, so that's a non-specific IVCD. And it is left axis, it's sort of a left axis that probably was caused by the inferior infarction. But you're right, it's sinus bradycardia, and then there's left axis up here. And the non-specific IVCD is down here with the rest of the conduction disturbances. And there's an older age indeterminate inferior infarction. I think that's about it. There's some non-specific STT changes here. You're right, it doesn't quite meet LVH. I'm not sure you'd code those. That's not the important part of this ECG.
Do we call left axis in the setting of inferior MI, Dr. O'Keefe?
You can call it. In this case, you get 1 point for it. They did actually measure LVH here. It's a male, but it's pretty close. As a female, it definitely would be because they just need more than 21. This is it's pretty close. Might have to change that. I mean, those STT changes kind of look like hypertrophy. So yeah. And left axis is one of the non-voltage criteria for LVH.
If you were going to code LVH, would you code LVH STT wave changes consistent with LVH or non-specific?
No, whenever you code LVH, you would expect to see and you see STT changes. You first think, is this consistent with hypertrophy? Let's see, I have one here. Okay, so this is a 23-year-old female who's got cyanosis and dyspnea. Again, if you think about the stem, this would be a relatively easy diagnosis.
Hypertrophic cardiomyopathy.
No, not that's actually not a terrible guess, but
Sinus rhythm, RVH, right axis deviation.
Yeah, that's it. So the reason I showed this one, so yeah, you got the right axis, you got this big R wave over here in V1, V2, V3. This is RVH, it's a young female with cyanosis and dyspnea. She's got congenital heart disease. These STT changes in the anterolateral leads, that's classic for STT changes of hypertrophy, that's RVH. If you look over here in STT changes secondary to hypertrophy and look at our definition, the LVH looks like this. That was a little bit what it looked like on that last tracing, not the RVH, but the one before that, where it's sort of borderline LVH voltage. So that's what LVH is, usually 1 in AVL and like V4 to V6 with they meet criteria for voltage elsewhere. For RVH, like it's more, you see this big R wave over here, and usually you see right atrial abnormality, right axis deviation, and then you'll see these are pretty striking repolarization abnormalities, but this person had severe RVH. So when you see LVH or RVH, look for the signs of hypertrophy too, because that's one of the coding criteria. So here we have a 63-year-old male with chest pressure and profuse diaphoresis in the emergency department. Anybody?
Sinus tachycardia with acute anterolateral MI.
Right. So pretty much right. But this is where, like, one of these things where it's where you really have to kind of know these sort of idiosyncrasies of the board score sheet. So you see this tombstones, right? This ST segment elevation, it is sinus tachycardia. I think it's like 17 QRSs across. I think it is anyway. But so we'll no, it's actually just under 100. So it's sinus rhythm. So it's very striking in V3 to V4, and if you have two or more leads in V3 to V4 that have contiguous ST segment elevation greater than 1 millimeter, you call anterolateral infarction. But if you have two or more leads that have ST segment elevation V1 to V4, it's anterior or anteroseptal infarction. So you have both anterior/anteroseptal and anterolateral infarction. And then there is significant ST segment elevation over here in 1 in AVL, so that's an acute lateral infarction as well. And then it's the sinus rhythm, and then of course the STT changes of injury, which so it's acute anterolateral, acute anteroseptal, and acute lateral. So you just have to memorize which exact leads they are, and there's two overlapping leads, V3, V4, where if you have ST segment elevation V3, V4, it's anterior. If it's V4, V5, it's anterolateral. But any questions on that one?
Would you still code STT segment changes associated with injury?
Yeah, right. I mean, I would. You probably get one point for it. Yeah. The only place where if you have left bundle with ST segment elevation that is concordant, going the same direction as the major forces of the left bundle, you can call ST segment injury, and you usually don't localize the infarct in that setting. But that's the only time that you can, that it's really important to code that ST segment injury. So here we have a 75-year-old female on diltiazem and flecainide, now with fatigue and dyspnea.
AV block, say, Mobius type 2.
Well, this is a very tricky one. This is where you have to really, not very tricky, but you just have to scrutinize. Yeah, it is AV block. It's it's actually 2-to-1 AV block. That PR interval is very stable. So it's and the other P wave is buried in the T wave right after the QRS here. So this is somebody who has AV block due to the flecainide and diltiazem. When we stopped it, the rhythm normalized. You could tell this is somebody who doesn't have a cardiomyopathy. Lots of times, if you see high grade AV block, you'll see QRS abnormalities, a widened QRS, whereas this got a nice narrow normal QRS, and sure enough, when we stopped the antiarrhythmics and the diltiazem, it just normalized right up. So the thing about 2-to-1 AV block is you don't know if it's Mobitz 1 or Mobitz 2 if it's 2-to-1 AV block the whole time. So in this case, yeah, you just do sinus rhythm and 2-to-1 AV block, and I think that's about it. Oh yeah, the left atrial, there's left atrial abnormality up here in V1. It's more than -1/1.
Would would you accrue any additional points for calling or coding for junctional rhythm, Dr. O'Keefe?
So no, this is not a junctional rhythm. This is 2-to-1 AV block. It's this is just a big long first degree AV block, and then one's blocked. So yeah, this is a sinus rhythm with a big long first degree AV block. Well, that's a good point. When you have higher grade AV block, like even Mobitz 1, certainly Mobitz 2, or 2-to-1 AV block, you don't have to call the first degree AV block like it is here. I mean, if you coded it, it would be neutral, but it's not mandatory to code the AV block in the setting of higher grade AV block.
And I think there's some confusion about the complete heart block, the possibility of complete heart block in this EKG. To your point, you had discussed about the consistency of the PR interval. So I think that's
Exactly.
what makes the difference here.
Yeah, if you measure the PR interval here, which we could do with the calipers, and it's very stable. And so that's how you lock the calipers and then just drag it across. Yeah, it's nice and stable. So yeah, that's that one. This is one that often shows up on the boards. For that matter, shows up clinically quite a lot too. This person, 68-year-old male, had a hip replacement 1 week ago. Now he's back in the emergency department complaining of sudden onset of dyspnea. Anybody?
Sinus tachycardia with the acute PE from S1, Q3, T3.
Perfect. Yep. This is, you got the S1, Q3, inverted T-wave T3, S1, Q3, T3, sinus tachycardia, the most common ECG abnormality in acute pulmonary embolism. You have you have this ST segment changes, which in the right precordial leads, which is kind of like what we saw with RVH, with strain, the RV. In this case, it's probably, we'd call it ischemia, just because the RV is overloaded with high pulmonary pressures acutely. There is an incomplete right bundle branch block here too. It doesn't quite meet the criteria. So, but there is there's an acute cor pulmonale, which here's another look at a tracing. This one's a little more right axis deviation even so, but still you got the S1, Q3, T3. Here you got, really striking repolarization abnormalities associated with this big pulmonary embolism. So, and like I say, sinus tachycardia is the most common finding. When you see somebody with a sinus rate of 60, it's unlikely that they have acute PE, but it can happen. But and like this is another incomplete right bundle branch block on this example. Okay, we're kind of running out of time here. One last one. So this is a 95-year-old female. By the way, these are all real cases that we've just pulled from our clinical experience here at the Mid-America Heart Institute. So it's a 95-year-old female pre-syncope admitted to the hospital.
Mobitz 2.
Yep, that's Mobitz 2. And other than that, so this is a drop P wave without any lengthening of the PR interval. But you know, this probably, because this is 2 times the standard PP interval. This pause. This is probably an example of SA exit block. And when we looked at this lady's telemetry, she was having SA exit block along with Mobitz 2 secondary heart block. And then a 95-year-old, you know, this is a heart that's beaten about 3 billion times, literally, about 1 billion beats every 30 years. And so it's kind of, you know, wearing out both the sinus node and the AV node. But yeah.
Can this be called a sinus pause?
Yeah, you know, for a sinus pause, it needs to be greater than 2 seconds. And this is 2, 4, 6, 8. Yeah, this is 1.9, 1.8, 1.9 seconds. So, so it's a bit of a. I'll show you here. Sinus pause. We have some really good examples of. In fact, I'm putting in a good sinus pause this week as the case. But yeah, so see, here's a sinus pause, and it's, you know, there's no. It's not exactly twice the, and actually sinus pause, you can also, you could code both a sinus pause and a SA exit block, but in this case, this is more than 2 times the usual PP interval, and there's, you know, there's no P wave in between, so.
Got it, thank you.
All right, well, for those of you who are taking the boards, good luck, and like I say, if you, you know, this is really set up for you cardiology fellows, and particularly if you're going to take the boards. But even if you're just trying to learn ECGs, I think this is a really great great tool. The O'Keefe ECG, you can find it at o'keefeecg.com, and we also have our book out that kind of has a lot of cases too, called Complete Guide to ECGs, that I wrote with Steve Hamill, used to be president of the Heart Rhythm Society, and he's up at Mayo Clinic. He's retired now, but yeah, that's Complete Guide to ECG also is a great study guide. That's what it's really made for. So anyway, thanks Yev for being the MC, and thanks everybody for taking some of your valuable time out of the weekend to go over some ECGs with us.
Thank you, Dr. O'Keefe, for sharing your weekend with us. Apologies, the last session has not yet been uploaded, but we will try here within the next week to upload both this session and the last one to Dr. O'Keefe's YouTube channel, which you can find, I mentioned, by easily searching for his name on YouTube, and you'll find some examples of some other lectures that we have uploaded already, and we'll keep you posted as far as future talks, and thank you again for joining.
Thanks,
Thanks,
Jeff.
Dr. O'Keefe.
Yeah, my pleasure.